at the opening symposium a very interesting discussion on checkpoint blockade. How long do we need to treat? Currently, we have experience with ipilimumab as the first generation of checkpoint inhibitors. Ipilimumab is given in stage 4 melanoma as 4 infusion in a 3-weekly interval. So after 12 weeks, you are done with your treatment, and all the effects we are seeing later on, including patients surviving for 3, 4, 5 years, are actually born in this 12-week treatment period. And we have roughly 20% of patients who have a long-term benefit using ipilimumab. These 4 cycles of ipilimumab are given without looking at response rate and tumor control. I mean, we know all these figures. We know that progression-free survival at 12 weeks is roughly 2 to 3 months PFS, and response rate in the range of 10%. But still, there are 20% of patients who have obviously a benefit which is long-term. So now we have the new treatment paradigms, including PD-1 antibodies, recently approved in Europe and across the world. And PD-1 antibodies have less toxicity. They have a very safe profile, currently, the recommendation in the label is that PD-1 antibodies are given for up to 2 years. So the question is, and these are infusion intervals of 2 to 3 weeks that a patient could stay on treatment. So the question is, how long do we really need to treat for maximum clinical benefit for these patients? That's, I think, academically an interesting question, and also of high clinical relevance for patients and doctors. I think we have some first evidence that in patients who achieved a complete response, so complete resolution of all metastatic lesions, that those patients where you stop treatment obviously have an ongoing treatment benefit without further need of treating these patients. So currently we have data from KEYNOTE-001, which is a phase 1 study using pembrolizumab. These treatment was stopped in more than 60 patients. Data were presented already at last year's ASCO, and we know that it takes some time to declare complete response, but as soon as you have the complete response, obviously it's a long duration of response, probably for years. Open question here is how long really is a complete response, and if a patient really would relapse, are these patients sensitive for retreatment with PD-1 antibodies? An open question. A second piece of evidence we have is patients who got treated with ipilimumab plus nivolumab, a combination treatment which was done in Checkmate 69 and Checkmate 67, and a pooled analysis of patients, of more than 400 patients, this pooled analysis. And this analysis showed that roughly 50% of patients discontinued because of toxicity, and median time for these patient group who discontinued for toxicity was 8 weeks. And if you look at tumor control, overall response rate, progression-free survival, you could see that these patients who discontinued because of toxicity had the same clinical benefit in terms of progression-free survival response rate, which was even a little bit higher than the patient group who continued treatment. So another piece of evidence that obviously you don't need to treat for indefinite time intervals. So the open question is at the moment whether patients who have to discontinue because of toxicity are more susceptible to toxicity, but also to response, so that there is some sort of inflammatory priming already, which has happened, which then sensitizes the patients to a good tumor response and also toxicity. That's one of the ideas. It could also be that we only need to treat up to a certain period of time, and whether we see initially a complete response or a partial response or not is irrelevant. Obviously, companies have more difficulties to stop early giving their drugs, because, I mean, obviously there is a certain interest, but payers' academic interest is high to have clinical trials designed which have also early stopping in comparison to usual in-label treatment. Financing of these trials obviously is more difficult. You need health insurances or federal financing of such a trial, but I'm pretty convinced that some of the countries and some of the paying organizations will be quite interested in performing those trials. In the UK, such a trial is currently close to opening over the summer, probably. So what we know is that checkpoint blockade, whether you use ipilimumab or the PD-1 antibodies, that toxicities we see are completely different to chemotherapy. They are completely different in their spectrum to targeted therapies. So since the immune system is affected, modulated, the side effects we are seeing are, most of them are related to the action of the immune system or the immunity. So all organ systems can be involved, from gastrointestinal system to the nervous system, connective tissue. Everything can be affected. The interesting thing is that ipilimumab as a agent which is affecting the priming of the immune system is obviously having a different side effect profile, is producing more, for example, GI toxicity and more hepatic toxicity, in contrast to PD-1 antibodies, which have a safer profile in terms of GI toxicity. There are almost no grade 3, 4 GI toxicities, but you are obviously getting more nervous system associated side effects we have not seen with ipilimumab so far. So, and the combination of ipilimumab and nivolumab is producing in roughly 50% of the patients grade 3, 4 toxicity. So that's really severe toxicity which needs to be handled by experts and standardized procedures in order not to harm the patient. I think we have quite interesting times in treating melanoma at the moment, and it's actually not only checkpoint inhibition which is catching our attention. It's also the new wave of combining targeted therapies with checkpoint inhibition, and there are 2 clinical trials which are currently in the phase of initiation, combining BRAF/MEK and a checkpoint inhibitor by Roche and by Novartis, which are globally targeting a new registration of these combined treatment approach, and everybody is hoping that that will be the next step in treating metastatic melanoma.